Dr. Sriharan leads the Systems Leadership and Innovation Program at the Institute of Health Policy, Management, and Evaluation, and teaches in the areas of health system leadership, innovation, and transformation. Prior to joining the Institute of Health Policy, Management, and Evaluation, she held senior leadership roles at the medical schools, hospitals in Canada and in the US, and served as a consultant for multinational organizations such as the WHO, World Health Organization, the World Federation of Neurology, Middle East Hearing Association, and the Canada International Scientific Exchange Program on issues of management, engagement, training, and governance of the health workforce and health system. Suzanne Mador has served as the Ottawa Hospital for over 32 years, starting as a frontline registered nurse, where she worked for many years across a diverse array of services. Suzanne achieved her Master of Nursing degree with a focus on nursing leadership, supported by her many years as a frontline clinical leader. Suzanne's strong leadership aptitude has been evident throughout her career, and she was awarded the Outstanding Leadership Award at the Ottawa Hospital in 2020. She was later that same year, she became the Executive Vice President and Chief Clinical Officer with accountability for the clinical operations portfolio within her organization. Following her passion for the profession of nursing, she also assumed the role of Chief Nursing Executive in 2021. Her most recent appointment as Chief Operating Officer and Chief Nursing Executive have resulted from her deep commitment to patient-centered care and focusing on our healthcare workforce within the Ottawa Hospital. Well, what a great conversation we're going to have with such experienced and exceptional people to speak to. We will be digging in and shedding light on the staffing crisis that's seen in health human resources today, recognizing and discussing the root causes and potential realistic recommendations and solutions, both in the short and longer term. So it's been a challenging time, and I know this conversation is much needed. Well, so thank you for joining us, Suzanne and Abby. Let's get started. I'd like to begin by asking the following question. Now, we've read many stories in recent months about the shortage of healthcare workers. Suzanne, you're dealing with these challenges at the Ottawa Hospital, and I know you have a lot of data locally and for the region on this. Can you set the context for us?
Thank you very much, Claude, and thank you for the warm welcome. Happy to be here today. So I will start by saying that most certainly we have seen growing vacancy rates and or turnover rates at the Ottawa Hospital, particularly over the past 2 years during the pandemic. But I would be remiss if I did not tell you that we actually had, we implemented our electronic health record just prior to the pandemic, and in fact saw some increase in turnover rates during that time, and then the following 2 years impacted by the pandemic. And so we've actually seen an increase in our turnover rates over the past 3 years. In particular, nursing, given it's 1/3 of our workforce at the Ottawa Hospital, the turnover rate has grown by 5%, where we've seen all other staff grow by 4%. So slightly lower, but essentially very similar. And when we compare this to provincial rates, our nursing turnover rate is in line with what we're seeing across the province, but our staffing turnover rates are slightly higher overall. The other challenge that certainly we've seen is on the recruitment end, and I know we'll get into talking about that a little further as the webinar progresses, but nonetheless, we are certainly challenged by both our intake and our output in terms of overall healthcare, the availability of healthcare resources.
Right. Yeah. And Abby, from your perspective, how can you add to this context from your perspective?
Yeah, no, thanks, Claude. And like Suzanne mentioned, the issue is not COVID I mean, COVID has exacerbated the issue, but the issue was in the pipelines were happening pre-COVID. So COVID was like, enough is enough, but we are done kind of situation. Like Susan said, the EHR transitions had led a lot of people to rethink about work. We know with any change initiatives, this happens, but we also have seen people leaving because the workload and the compensation was not matching. So there is that issue, like, why do we have to do what we have to do? And then we also have in healthcare, especially in nursing, an aging workforce. And then the pipeline of recruitment and the new generation who are coming in, they are not happy with the type of work environment. So the policies that are based on the 1960s and 1970s and 1980s workforce lifestyle, right? You become a nurse and you stay as a nurse and you retire as a nurse. That's no longer the case. People want to do more. They will stay in the front lines and then they want to move on. So people want variety, people want different type of work environment. And unfortunately, our system and the design has not thought through the process. So those are all of those factors that are leading to this. And COVID actually gave people an opportunity to sit back and say, what do we want out of life? What do we want out of profession? And that's, I mean, your topic of this seminar series, work and wellness. That's what people were looking at, health and wellness. That's what people were looking, and that's kind of what happened, and that's what's happening. And hopefully the solutions will actually address these root causes as opposed to going back to let's bring in more people and put them into the same environment.
Mm-hmm. I get, and you must see a difference between what we call generations of workers. We often talk about millenniums versus Gen Z. Does that manifest itself in how people respond to working in the profession?
Absolutely. I'll tell you another consequence of the high turnover are the shift that we've seen in terms of the demographics. So what I can tell you is that 16% of our nurses were between the ages of 31 and 40 in 2016. This has now grown to over 27% today. And so you can only imagine, as the generations change, they're more comfortable, as an example, with technology. They're interested in, or more focused, shall I say, on work-life balance and having flexibility in the workplace, and some things that are not always afforded within our structured environments.
Yeah, and yeah, especially the nursing population who are young mothers or caregivers, and sometimes it's dual caregiving, right? Not only for the children, but also for their parents. And when they're in that sandwich generation, and then the work is also not flexible, that's when people are saying, I need flex arrangement. And then the opportunities are out there, right? We have other opportunities within Canada, but we also have global opportunities. So people are saying, okay, where do I go and find that life that I want, as opposed to, I am from this region, I really like the healthcare organization, I'm going to spend the rest of my life working for this organization, no matter what. So I think that international global opportunities are actually also recruiting people.
Indeed, and I know we'll get to that in a moment. I would like to make sure people have an opportunity as well, and our participants, to ask a question. Again, for those who have just joined us, you can ask your question in one of two ways. You can raise your virtual hand, and our events team will make sure you're unmuted and you can ask your question live. Or alternatively, you can type in your question in the Q&A at the bottom of your Zoom bar, and we'll read out the question for you and have our panelists comment and answer your question. So feel free, as we continue our conversation with Abby and Suzanne this morning, to ask any questions you may want on this topic of health human resources crisis that we're seeing in our system at the moment. So I guess picking up on this, now that we have a bit of a context for this issue of HHR staffing, what do you see as some of the ongoing challenges that we're facing now, locally, regionally, or even nationally? Suzanne?
So, sorry, I'll chime in first. So the pandemic obviously has exacerbated some system-wide challenges that we've had in healthcare, and certainly none more apparent than some of the challenges we've had at the Ottawa Hospital. Things like an increasing number of emergency room visits, particularly some lower acuity patients because of the lack of primary healthcare physicians available. Increasing numbers of patients who are awaiting long-term care, delays in ambulance offload times, which impacts their response to the community, and then the number of patients who have been waiting for much needed procedural care, including surgery. This has impacted some of our smaller hospitals within the Champlain subregion in the way that they've had to close their emergency departments, thereby putting further stress on the system for those hospitals that continue to run their emergency departments. At the Ottawa Hospital, we are the only tertiary quaternary center in this subregion. And so there is not a point in time where we have closed or would consider closing our emergency department. Mm-hmm. So it is certainly quite a challenging time for patients and our communities, in addition to within the organization and our healthcare resources.
Yeah. So adding to Suzanne, one is the workforce leaving workforce, but the workload has actually increased since COVID due to all these ripple effects, right? Primary care physicians not being available, partly because some of them are actually retiring, that workforce is retiring or transitioning out of workforce. Increasing number of COVID cases, long COVID, other issues that people are seeking emergency care, and then everything else, resource allocation issues, all those things are actually creating additional issues. So it's like the hospitals can't actually get a breathing room to think about what is the right strategy, because you kind of need to find all these band-aid solutions just to keep the system running. So we are functioning in this band-aid mode, and sometimes some organizations can't actually sustain, because every organization, every region of Canada is actually facing the same thing. And we also have very limited pool of workforce to tap into. So this is really creating a major crisis, and that's why we are seeing this closure. And this is not only a Canadian issue. I do a lot of global studies, and this is happening elsewhere. So our nurses, we are losing nurses to other countries as well. NHS has an international plan to recruit nurses to the NHS system. US hospitals are trying to recruit. So we are going to see a lot of brain drain as well. So this is not only nursing, but we are going to see it for other professions, physicians and other professions as well. So we not only need to think about how do we build our capacity, but also how do we sustain our existing workforce so they stay here.
Yeah, we'll definitely pick up on that, because there are many factors that motivate someone, and the retention issue, and compensation is one thing, but there are other factors as well. We'll come back to that in a moment. We do have a question here from one of our participants, our attendees here. I will read it. It says, I definitely resonate with what you just said, because I have young ones, and I've been stagnant in a primary care setting because of hours and flexibility. But I know I have the skills and drive and passion to help in acute care, not to talk of better compensation than I get now. How do we accommodate nurses like me to ease the burden in acute care without sacrificing the family work balance? So who would like to take a crack at this question here? Suzanne?
Sure, I'll take a stab at it. So I would tell you that particularly in an organization such as the Ottawa Hospital, we have a very large nursing workforce, and we are a 24/7 operation. So challenging as it is, we understand it's also the employees' market today, trying to meet the demands of the workplace and meeting the care needs of the patients while balancing the need to provide that flexibility for our workforce is key. Again, focusing on the opportunities that avail to us. We live within some restrictions. We are a unionized environment. So I must bring that forward. So we do have some structural elements that are more challenging to overcome as a result, but most certainly listening to our employees, understanding how we balance the need for flexibility, things like shift work. There are many opportunities within an organization such as ours that do provide more opportunity, I would say, to be able to meet the demands.
And I guess on a broader picture, Abby, do you see an ability for healthcare environments to create that flexibility that Suzanne just spoke of?
Yeah, no. I mean, I think like Suzanne talked about, I hear the similar stories from chief nursing officers in many hospitals who understand this and who are willing to do this. What we are struggling with is this regulatory environments. The unions, the policies sometimes have limitations on, and then it's also some of the policies beyond just healthcare, right? So in terms of how people can be compensated, how people can be recruited, what's the work hours that you can allocate. So there's so many controlling environments that the nursing and medical leadership has to go through. But for me, what the hope is right now, and I'm very excited about, is the leadership in most hospitals in Ontario really understand this. They understand the work environment has to be employee friendly. They understand that they need to rethink that flexibility. So I am very hopeful we are going to see a lot of changes happening, and nurses like Nancy who wants to make that difference, they will have that opportunity. And what I am going to call is people like Nancy who really want to do this, who have the passion. Don't sit back. Reach out to your leaders, talk to them, see what opportunities are there and how you can find that balance, because until you ask, you won't know.
I want to come back to a point that was made around emergency room closures and creating a burden on other in the sector. I'd like to understand, I mean, I'm sure our viewers would like to understand that better as well. So what is the kind of coordination that takes place to say, hey, heads up, we're about to close this weekend and somebody else has to take up the demand that would otherwise come to our hospital. Does that coordination exist? Or if it doesn't, what could be done to assist with this so that at least there's some warning that something is happening and others can prepare for it from a staffing perspective?
Yeah, so absolutely. We work in close partnership and collaboration in our sub-region. We're very fortunate to have great relationships across the sectors. In addition, we work closely with Ontario Health East as a region, so that any hospital that is contemplating and or the pressures leading them toward looking at closures, there is an escalation process whereby Ontario Health East is notified, and then other hospitals within the region, that trickles down. Now, depending how what the impact is anticipated to be in terms of the volume coming into that emergency department, et cetera, and which hospitals are in the surrounding geographic area anticipated to have that the impact or faced with the impact, there are actually multiple conversations. We've had many phone calls working with the regional paramedic services, et cetera, just to ensure we're always looking out. Everybody's best interest is the community and providing services that are much needed. And so we work together to be able to balance that. It does not make the challenge necessarily easier, but certainly makes our response to our community easier.
Right. Okay. Thank you very much, Suzanne, for that comment. So there's obviously a need for more people joining the ranks of the healthcare, and we're seeing that people are leaving, but they're not necessarily leaving the sector completely. So what I've heard you say is that some are leaving to go elsewhere within the healthcare system, either because the conditions are better, it's a region that they want to live in, perhaps, or the compensation is better. can we talk a little bit about this, about, okay, what are you seeing? What are those various factors that are causing people to stay in the healthcare system, but not in our local, or maybe not in Ontario? What's driving that exodus?
So I actually now refer to this as a wicked problem. You know, the definition is such that there really is no solution. And I think we have some opportunities. Not sure, the problem seems so big right now that we all have to work together. You know, I'm talking all levels of government, academia, all of the organizations across the continuum of care. If we have a precious or finite number of resources and we're all just moving them around, robbing Peter to pay Paul, at the end of the day, we're actually not doing justice in terms of being able to deliver our mandate. So I would also say solutions are not one time. We need short, medium, long term, all working together. And with that dichotomy between the increase or growing volumes of patients, but the reduced number of workers, it's really causing this wicked problem that I refer to. We're seeing obviously the increased number of staff turnover, but at the same time seeing the decreased availability in terms of the outputs of schools. And Abby referred to this earlier, less people going into healthcare professions.
Right.
And really to get ahead of that, you know, we're talking 4 years, in some cases, anywhere, I guess, from a year, 4 years or longer before we're turning over new healthcare providers. So that is also certainly adding additional burden for us. Now, this competitive market where we've seen these unprecedented charging of exorbitant fees, right? These attractive agencies that can pay their staff more, or travel opportunities. You know, I think of nursing in particular, and there were a number of nurses who left to do travel nursing or a 9-to-5 community type role where it allows them that flexibility that we talked about. And I referenced earlier, in an acute care setting, it's a little more challenging to be able to provide that. So certainly more attractive opportunities, better work-life balance, ability to travel to desired destinations. And now, you know, with more public-private partnerships coming on board, again, that setting of Monday to Friday regular hours is really proving to be more of a challenge in terms of that competitiveness.
A wicked problem, as you've said, you know,
Yeah.
difficult one to
No,
solve. Abby?
No, that's a very well said. It's really a wicked problem. But one of the things that's shedding light right now around this problem is even though work conditions, the burnout, all of these things causes people to think about leaving the workforce or leaving the organization, the number one root cause of people leaving the organization is when they don't have support of their immediate manager. So it's not the leaders, it's the immediate manager, it's the immediate environment. That's one of the root causes where people say, I can't work in this environment. I don't have that psychological safety. I don't have the opportunity to go and say, today I can't come because my child is sick. I can't do this because like I need to go home early to pick up something. In those kind of little opportunities, this is really a human relation, human behavior thing. And when the organizations are not addressing that issue, that's when people are saying, I'm going to go for a different environment that might give me that opportunity. So one of the retention strategy like organizations are starting to focus is really leadership training, or rethinking that leadership training to teach about the importance of organizational safety, psychological safety, management, communication, those kind of things. So people can safely say, I really need to do this without being stigmatized or penalized for that behavior.
Yeah, well, those are very important strategies, because it's one thing to increase the pipeline and try to have more people join the ranks, but if they exit at the same rate, no one's better off. So obviously there is to be a strong retention strategy here.
Yeah.
Well, we have a couple of questions here in the pipeline here, and I'll save one of them because we'll be talking about partnerships in a minute. One from Doreen here says, I've recently heard about contract nurses who work part-time in Ottawa, but fly into other regions of Canada, such as BC Interior, on all expense paid short-term contract. What does the province need to do to retain nurses in place in Ontario? Or is this future one of part-time transient nurses who enjoy work location flexibility? Maybe Abby, I'll start with you on that one.
Yeah, so I mean, one thing is we can't really control human behavior, human migration. People are going to choose and do what they want to do, but we could actually change some of the reasons for them doing these things, and try to, as organizations, have strategies to address those things, right? It's only not BC, but I see a lot of travel nursing happening to Australia, New Zealand, Texas, UK. So all of these opportunities are either providing them better compensation, better lifestyle, better opportunities. So if we don't address and we say, because you have a nurse and you need to be within that Band-Aid thing, and you have to work on these things, and you don't have any flexibility, people are going to leave. So it's really understanding what the other organizations are offering, what is enticing these people to travel or leave, and then providing those solutions. Because we can't really control and say any nurses from Ontario can't go to BC. That's not going to work. But if we say, if someone is saying like, no, I really like what I'm doing in this organization, I don't really need to unpack, uproot my family and travel. They are going to do it. But the other thing that we need to think about is a generational change, like Suzanne talked about earlier too. We are seeing a different type of generation of nurses and other health professionals coming through. They want to travel, they want work-life. I remember recently for a medical student class, I did a value exercise. Every year, normally the values will be, I need to have a high ranking, like in a power, all those kind of, top, high, direct, D kind of things. This year's cohort was saying, I want work-life balance. I want family. I want spiritual meaning. So it's a very different generation wanting very different things. And it's not about achievement, it's about value, it's about grounding. So how do we offer that for the people? So travel might be the only opportunity for people to get that, and that's why they are doing it. So again, rethinking our human capital strategy is key in this issue.
Right. Now, healthcare is a provincial jurisdiction, and each region has its sets of regulations for the people who work in certain occupations. So how does that work for someone who is registered in a province to work in another jurisdiction? How easy or arduous is it to break those barriers and actually do what you just suggested, Abby?
I just jump in. So each, again, like you said, every region, every province sets their own regulatory environments about this working. And when a province or a region or a country is facing this health workforce crisis, they are going to have leniency in terms of the licensing process. Not the leniency in the sense like they are going to bring in everyone, but the process is going to be, the red tapes are going to be avoided, right? So this is going to create opportunities for people to travel, people to take on the jobs. And I see this in the UK. I'm seeing it in US right now. There's a lot of changes in terms of the regulatory environment and the compensation structures that people are going to find those opportunities. So unless Canada and each province innovates in the way we are going to work, we are going to lose our workforce. Even if we recruit them, we train them, the organizations will spend months, years, train them, and then we will lose them to another organization. We saw that during COVID, right? Long-term care lost a lot of nurses because we needed nurses for vaccine delivery, and the vaccine delivery was paying $50 an hour when long-term care was not paying in their 20s. So we are going to, it's a competitive market. We really have the business mindset to address the healthcare problems instead of looking at healthcare as a healthcare problem.
Okay. Anything you'd like to add to this, Suzanne?
No, I think the one thing I did want to add was just some information around retention. We're talking a lot about recruitment, but honestly, equal is the need to focus on our retention. So let's make sure we're keeping the people we have. Back to Doreen's question, how do we stop them? Again, regulatory bodies can't say, you know, nobody can leave this province and go to another province. I mean, certainly you can make, you know, the uphill journey a little more arduous for them, but that is not the right thing to do. I think we need to focus on the people we have and keeping them with us. So we actually conducted a retention and morale survey for our nurses in the spring of 2022. Now we had a 33% response rate, so approximately 1,500 out of 4,500-ish nurses. So 25% of those nurses rated their personal morale as poor, and 44% rated their overall morale on their unit as poor. So 44%.
Wow.
The top 3 factors that contributed to nurses leaving those units were personal well-being, workload, and staffing resources. So not having enough resources to carry out their role, which of course led to increases in workload. Then when asked what were the top 3 factors that would improve the morale in their perspective, they indicated number 1 to be increased wages and premiums. And this is what led me, Abby's comments led me to think about this survey. So increased wages and premiums, followed by improvements in workload, and then scheduling improvements and flexibility. So much along the lines of what we've talked about here today. I think in terms of increased wages and premiums, you know, very telling in this province, I would say, was the impact of Bill 124. And we can't ignore the impact that that had, but we also do know as a nurses union that they are entering into negotiations early into next calendar year. And of course, anybody in the nursing world is really hoping for some improvements by way of compensation and acknowledgement of that profession, I would say.
Well, yeah, we're hearing a lot about the impact of Bill 124 in a lot of public sector related organization, and I think it's going to be ongoing pressures across the province, frankly, in all these sectors. So I think we'll have to stay tuned to watch how that log jam will be broken over the next while, because it's compounding for sure. We have you said something, Suzanne, that has piqued Esther's curiosity here, and she has a question in regard to your earlier statement around public-private partnerships. Her question is, what is your opinion on patient co-payment for primary care, as we're seeing in some other countries? Is this a possible solution or a slippery slope?
That's a good one. So I think when I say public-private partnerships, I really need to highlight the public portion of that. I do think it is a slippery slope. I know that internally we have so many discussions and are really challenged by the thought of leaning toward any type of privatization of healthcare. Now, specifically related to copay and primary care, I haven't spent a lot of time thinking or talking about that specifically, but certainly in the realm of privatizing healthcare, I really don't think that's where we should be going today. I think there are many opportunities ahead of that that we need to explore further and continue to build on the healthcare system that we have created in this country and in this province today by focusing on the public portion, but how we can leverage the opportunities through partnerships.
Yeah.
Maybe.
That's very well said, Suzanne. I think like the public-private partnership dialogue is more focused on maybe this is another band-aid solution. We need to fix the problem, right? But what we have is we have actually a pretty good healthcare system. The problem right now is the pieces of the system is not working together. We have primary care with workforce challenges. So when there's an issue in the primary care, we are sending patients to emergency rooms. When emergency rooms are overwhelmed, we are again having workforce issues there. And then emergency rooms to GIM wards or like any internal medicine specialist. So the system is there. We have really not figured out what's the right innovative solution for the 2022 problem that we are facing. It's not really the only privatization, like Suzanne talked about. It's about how to work along with public-private partnership. How do we actually use the public system and think like private system and improve some of the workflows and leakages that we see in the process? Why do we need to do X, Y, and Z? Because there are so many processes that we don't need, right? So it's that kind of thinking, why are we doing what we are doing? What can we do to do differently, more efficiently? And in fact, if we actually engage our workforce and leaders in terms of thinking through this, we'll be able to find really cool solutions. So I think it's time for us to really bring that innovation mindset to the public system and again, make our system more efficient before we jump into let's bring the private sector.
Okay, thank you, Suzanne and Abby, for a good conversation on this public-private piece here. I want to switch gear a little bit because I'm biased here. We are in the education system, and we are in helping to develop the talent pipeline for your sector. So question, we know that partnerships are important with local colleges and universities. Certainly we have a great ecosystem here in Ottawa with Algonquin College, La Cité, University of Ottawa, and Carleton. And there's work happening to help bring internationally trained healthcare workers to transition as well into the sector and perhaps do this more quickly. Can you tell us a bit about that as a process, as something to help with satisfying the talent pipeline, and how is that working? Maybe Suzanne?
Sure. So I think, as I alluded to earlier, that this partnership between academia, government, healthcare sector is crucial at this time. So in terms of creating the pipeline, we first have to understand our data. So what is it we're lacking? How do we project our needs for the future? It can't be just about today. This is where we got caught. Essentially, I won't say we were sitting comfortable. I think there was a general awareness that we were faced with shortages in healthcare and the world was changing, but we really did not anticipate the impact of the pandemic, and we need to learn from that. So we need to understand who our workforce is, where our challenges are, and then adjust, be innovative and creative in terms of creating that pipeline. And it can't start when they're already within their university programs or college programs, right? It has to be long before that. So I think you need to start thinking about healthcare roles early on in everyone's life, essentially, and what that pipeline could look like, how you build that. I'll give you one example. We went out to public and created a role called the hospital support aide. And so the hospital support aides have no healthcare training whatsoever. They're unregulated healthcare providers, but they've come into the hospital environment and they're helping the teams. So what are the things that they could do to provide, it's not necessarily providing care, but it is inclusive of the care team in terms of, maybe they're running to get a newspaper for a patient or sitting and talking to them while they eat their meals, etc. There are many, many opportunities for team members within the healthcare realm. And so we've had a number of these hospital support aides. I heard yesterday, we have 3 that have applied for nursing school now, just being involved in that environment and feeling like they're making a difference to patients. And so I think that pipeline that we talk about can't just start once somebody has entered into the program, right? Any health related field, it has to start long before that. And I think in terms of internationally educated workers, obviously we're working with Ontario Health and the College of Nurses around the Supervised Practice Experience Partnership. program, and we have 61 participants through that program at the Ottawa Hospital. But it's also a recognition that, again, their journey and their onboarding doesn't just stop once they've come into that program. Their transition into the workplace, how we support their learning and development over the time, their integration into the team, all very key, and need to have the resources available to do that, and the expertise available to do that. I think leveraging the role of the essential care partner, we did much of that during the pandemic, providing training for essential care partners, understanding the importance of their role and how they play a part of the team. So it's not just the traditional healthcare worker that we're talking about, it goes well beyond that.
Thank you, Suzanne. Abby?
Yeah, no, Suzanne, those are really, really good examples. But this is where the colleges and the universities could step in, is instead of thinking through the traditional programs, nursing 4 years, medicine 4 years, this is an opportunity for the colleges and the universities to innovate. We have healthcare aides, we have PSWs. How do we take those professionals? So, and people go into PSWs and they stay as PSWs for 3-4 years and then they leave professions. How do we take them and retrain them or upskill them so they could actually address certain other areas of the organization? So this is where hospitals, care delivery, and the universities and the colleges have to partner and think about the new type of workforce. With AI and digital technologies coming into healthcare, how do we prepare this workforce who are prepared to work alongside the AIs and the digital technologies? So again, rethinking and innovating in our training space will actually help us address the problems, like Suzanne said, instead of focusing on right now, future thinking. How the future of workforce in the healthcare sector, and how do we kind of build that? So I'm going to challenge you, the Algonquin College and other colleges who might be hearing, is to think through this, because you have a market opportunity right now to innovate. Take those healthcare aides and think about how do we give them skills so they could do more than just sitting with the patients. How do we help them? I mean, opportunities to think about how do we maybe take some of the task away from nurses and the doctors, that where they're actually spending more time in the administration and putting information into the technology, and then they do patient care, frontline patient care, but they have support staffing. So a lot of opportunities, a lot of excitement. I mean, this is an exciting time for innovation.
Indeed. I'm hearing a bit of scope of work issues here, but listen, absolutely, it's important we talk about it, and it's important to, again, work through those wicked problems to see how we can actually decouple some of those things we've traditionally done and do them more innovatively, that allows us to do perhaps more with the resources we have. I do have a question that's kind of tied to this. It comes from Erin, and it's and she's at Algonquin College, so she's in that milieu. She said, the bottleneck I see in my program area for mitigating the HHR issue is clinical placement availability. Curious what the panelists' thoughts are on creative strategy to train more students.
Yeah, so it's interesting because I've had many of these discussions with our local programs as of late, and with placement, it's not so much that the placement isn't available; it's the clinical preceptors and instructors that don't have availability, because the limited healthcare resources and nurses, if I use them as an example, that we do have are already working as much as they want to work. Better work-life balance more often now doesn't mean a full-time job back at the hospital and then another part-time job teaching students. And so it's really a challenge when you have this scarcity and you're trying to spread them in multiple parts. And so we have been entering into discussions around opportunities. So there are other healthcare providers that have skill sets within similar scope and or expertise in certain realms. So I'll give you one example. If a nurse is learning chest care and or chest auscultation, can we use respiratory therapy to teach that portion, as opposed to using the same traditional worker? Because scopes, I agree with you, Claude, we're limited sometimes by way of scope. We need time to think about how we broaden that. But at the same time, we have other skilled workers who have same or similar scope, or sometimes we're not even using or leveraging them to the full scope. And so we need to think about that. Do you always have to have the traditional models for clinical placements? The other opportunity is virtual care and simulation. How do we leverage those opportunities, right? Digital technology, simulation, to provide some of these learnings and opportunities. Certainly not the same when I went to school more than 33 years ago, but but we all have to start to get our head around. In fact, I wouldn't even say start. We have to get our head around this sooner than later.
Yeah, and you touched on that, the use of technology, whether it's AI, augmented reality, gaming, all applications that can help put someone in a artificial milieu, but start to give them sort of the tools and the knowledge and skill that can be transferred easily enough in a real setting, so that it's helpful. They don't have to start from scratch, and maybe can shorten the time that's needed with a preceptor on clinical placement. So good point there. We talked about the role of colleges and university. Lucie adds, how can the CNO and the CNA help in these areas as well? I wonder, Abby, if you've got some thoughts on this.
Yeah, I mean, I think like everyone understands this is the healthcare workforce issue needs to be changed. And like Suzanne said, we are not training nurses 30 years ago. We are training nurses in a different environment. Nurses are working in a different environment. So the colleges and the organizations are starting to think what they can do. But I think it's a collective opportunity for all of us to say, how do we change some of these policies? How do we rethink even just the simple things as 4-year curriculum for nursing, right? And what are some of the things that we don't really need anymore? What are some of the things in the curriculum that was based in 1930s work environments or 1960s work environment? And then take away those things, bring in these things. How do we change the regulatory things? So it's a collective dialogue. I know that dialogue is happening. There's lots of national level programs where nursing, medicine, interprofessional dialogues are happening as well. So I'm hopeful this crisis is an opportunity for innovation. Everyone is looking for innovative solutions, and we need to continue to have these dialogues, like these forums, bringing in frontline practitioners to also share these things. And if you have ideas, share those ideas with the CNOs and other organizations.
Indeed. Thank you very much, Abby. Part of the attraction of staying in healthcare is the hope, the opportunities that await someone as they navigate their career. Suzanne, you talked about, and Abby, both of you talked about, how the career used to be. You became a nurse and you were a nurse for your life. People are looking for specialization. They're looking for laddering, either laterally or upward mobility. Jennifer asked, is there a pathway from PSW, for instance, to RPN to RN? And I'm sure within those large occupations, there are probably some sub-laddering also that's possible to keep someone interested, keep someone motivated to learn, to acquire a new skill. So can you comment on whether those ladderings do exist and are they helpful in the retention strategies?
So I would say absolutely they exist. We need more of them. I'll give you a couple of examples, or maybe a few. One where we partnered with our local college, where we provided upskilling for some of our support service workers, so transportation workers and housekeepers, as an example, to upskill through the PSW course offered through Algonquin. And there was a partnership so that we could keep their salary whole, but afford them this opportunity to upskill. And one of the others I think of is OR nursing. So we knew that there was no way we had time to wait for the number of OR certified nurses to go through traditional programs and be in a place where we could increase our throughput to see that we were meeting some of our challenges in terms of
Mhm.
backlog. So we created an internal program, of course, working alongside school-based programs, historical or traditional programs, to understand how we could deliver an internal nursing certification for those interested in going to the operating room. And so they didn't have to take time away from their families or their workplace and their salary to attend a traditional program. And we're actually, being paid while they were learning on the job. And so we were able to create 75 positions to upskill OR nurses. We're looking at micro-credentialing for RPN roles,
Mhm.
Respiratory therapy to anesthesia assistant, scrub technicians. So we have medical device reprocessing technicians who have gone away to upskill. I say gone away, I mean gone to school to upskill to become scrub technicians and actually be in the OR environment. And so we built upon their knowledge that they had as a medical device reprocessing technician and provided that additional learning. So there are many opportunities, but I think we need to keep thinking about this, and we can go much further than we have today. And it's working together collaboratively that we'd be able to do that. The one other thing I'd like to just say is that, we need to focus on collaborative team-based models and interprofessional learning. More and more, we're leveraging scope of all healthcare workers, and it's important that they understand the role each one has to contribute to that overall care. And we need more of these environments, starting with our education system and building upon that instead of educating in silos. And this is no matter where we are, whether it's in academia or in the hospital environment.
What a great conversation. We are at the end of our show. Unfortunately, I know we could talk about this for a long time, because this is as you said, I think, Suzanne, a wicked problem. I do want to thank both of you, Dr. Srihanara and Suzanne Mador, for joining us this morning. You've created a great context for the problem that we have, and brought some examples of where we've been able to work collaboratively and innovatively across the system to bring solutions to the forefront to deal with our current and future healthcare crisis that is manifested itself through the human resources side of the house. But we appreciate your time and for sharing your insights and knowledge today. This session has given us a lot to think about. We're delighted for you to join us. This concludes our Health and Wellness Speaker Series event. I'd like to thank you, our audience, for starting your day with us. And we look forward to having more conversations with our communities in the future. Thank you. Miigwech and merci.